All right, everybody, we're gonna go ahead and get started. I'm sure people will still be trickling in a little bit, but we're right at 12:01. We've got Heather presenting, we've also got Justin right there, who's presenting. Go ahead.
Hi, everyone. I'm Heather Macalma. I'm one of the occupational health residents. And the article I'm presenting today is effectiveness of the secondary prevention protocol for occupational contact dermatitis. And the article was published in 2017 in the Journal of European Academy of Dermatology and Venereology, done at the University of Trieste, occupational medicine.
Hey, Heather, I'm sorry to interrupt. Can you check and see if the microphone is on? There's a little button to click it on. Right, so people on Zoom are saying that it's a little low. I can't hear. Keep testing, keep trying a little bit. I'm not hearing that come through.
Operator error. Okay. All right. So I'll kind of step back. So this article is about the effectiveness of a secondary prevention protocol for occupational contact dermatitis from the Journal of European Academy of Dermatology and Venereology, done in at the University of Trieste in Italy. All right. So for some background about occupational skin diseases, they're considered one of the most common and some cited as the #1 most reported work-related disease in industrialized countries, with rates ranging from 20 to 50% sometimes. And most of those occupational skin diseases are due to contact dermatitis. This set of diseases carries a very high cost to industry due to workers sometimes needing to take sick leave and even leave their job as a result of their disease. The most affected demographics are occupations that involve wet work, like bartending, housekeeping, healthcare workers, and women and younger workers being most affected as well. The main methods for prevention are fall into the categories of engineering, PPE such as gloves, removing the substance such as with soap and water, and in general maintaining good skin hygiene. So it's understood that maintaining the skin barrier is key in preventing occupational skin diseases, and the skin barrier comes mostly from the stratum corneum, which is the top layer of the skin of the epidermis, and that's what prevents the loss of water across the epidermis. And most clinicians don't really have a great tool to measure objectively how well the skin barrier is intact. But it was found that you can measure transepidermal water loss, and this can be a quite sensitive measure for testing skin barrier integrity. And for that reason, it was chosen by this research group to study the course of occupational dermatitis in a set of workers in Italy. So the purpose of this article was to use a combination of clinical assessment and also this objective measurement of the transepidermal water loss to assess their effectiveness of their skin care training protocol on the course of these workers' occupational contact dermatitis. They conducted a prospective cohort study, and they took workers who were diagnosed with occupational hand dermatitis in their clinic from January 2011 to December 2013. After gathering some history about their disease and through a standardized questionnaire via phone interview, they invited those cases in for a second clinical evaluation, which would include an allergy skin patch testing, and as well as baseline measurement of transepidermal water loss. And then after this, they was each of the subjects received standardized training on skin care hygiene. So after 3 months following that training, they were brought back in to assess outcomes of their clinical course of the dermatitis and also to remeasure their transepidermal water loss. And so they broke down these these phases of the study as T1, T2, and T3. Because there's no standardized value for normal transepidermal water loss, they recruited an equal number of controls without hand dermatitis that were sex and age matched to their cases. For statistical analysis, they used student t-tests to compare between their controls and exposed for the continuous data, and then a chi-square analysis to compare their categorical data. And then in the cases that were followed up, they used generalized estimating equations in order to identify what factors might be predictive for persistence of the dermatitis as their dependent variable. And they set their significance threshold at a p-value of less than 0.05. For the results of the study, in the T1 group, they were able to gather 143 patients who had confirmed diagnosis of occupational hand disease across that time period. And they reached out via telephone to do their initial information gathering questionnaire. And they were only able to reach 101 of those cases. And then of those, only 65 chose to proceed with the study and receive training. After the training, 13 of the participants dropped out. And so the remaining 52 participants were further broken down into whether or not they were strictly adherent to the skincare training or partially or non-adherent to the skincare training. Kind of one of the main measures they were looking at are whether or not they had ongoing symptoms. So those who were brought in for a baseline exam, 60% of them had ongoing symptoms. And then after the training, it dropped to 42.3%. But when you subcategorize them by protocol adherence, those who were strictly adherent had 29% who still had ongoing disease, whereas 62% who were non-adherent or partially adherent continue to have dermatitis. So looking at the main outcome measures here on this table in the T3 column, as I described, the ongoing dermatitis dropped from about 60% to 42%. And there was decline in how many had glove-related symptoms, the need for dermatological examination within the last year, and those who needed to take sick leave due to their disease. Looking at the follow-up group to get a better idea of what would be, what are predictors of persistent dermatitis. As I mentioned, they use the generalized estimating equations, which from my understanding is a type of multiple linear regression that allows comparison over time incorporating multiple predictors and with non-normal data. So they use two different versions of the two different models using the generalized estimating equations. And so in their first model, in that column, model 1, they use male sex as their reference point. And then in the last column, they used minimal hand washing of 0 to 5 pounds per day as their reference point. Using both of these, they found that age, gender, and work seniority were not pertinent. They didn't have that didn't affect their risk of having ongoing disease. But when they looked at the number of times people wash their hands in a day, they found increased odds of having ongoing disease with high amounts of hand washings. But in both of those models, they found no statistical significance. For the second model, using minimal hand washing as a reference, they found decreased odds of having ongoing disease at the 3-month follow-up. And that was whether they were partially or completely adherent to the skincare recommendations. And again, not statistically significant. And then kind of the last key measure that we're looking at is the transepidermal water loss. And this one they did find to be strongly predictive of persistent disease with statistical significance. So the conclusion that the authors arrived at was that the skincare training is an effective method to reduce contact dermatitis in affected workers, particularly those who have who adhere strictly to the preventive recommendations. And they also found that the transepidermal water loss was strongly associated with ongoing symptoms of dermatitis. And the extension of that is it could be a clinically useful tool, not just to monitor disease for those who are under treatment, but also to potentially identify early disease in those where the worker may not have symptoms yet, or the disease may not be very obvious on a clinician's exam. So in terms of the strengths of this study, I felt that using an objective measure for the outcome really added a lot of strength to the study design. And in particular, because it is applicable to changing clinical practice potentially, and also to affect industry by potentially reducing costs to the industry of having to lose workers, retrain them, and also improve quality of life for individuals who are affected by this, as it can potentially avert unemployment or loss of a job. In terms of weaknesses, I found that the loss to follow-up was one of the things that were not ideal about it. Of those who were recruited into the baseline evaluation, they lost about, I think it's 46 people or so. And so that created a very small study size. And then after that, the loss to follow-up was reasonable, about 20% after the intervention was applied. I felt that the follow-up was a bit short for the most important outcomes in my mind would be retaining workers in their job and reducing sick days lost. So had the study been a little bit longer, I think that might have been a helpful finding to demonstrate. As with many prospective studies or those involving questionnaires, recall bias is a factor here as well. And then as confounders, I felt that the heterogeneity of the cases in terms of the types of workers who were collected as cases, the type of work they did, and the differences in their PPE could potentially affect how their clinical course would go. The most, I guess, troubling or difficult finding for me from this study was that, well, it's not apparent on the slides, I saw a number of incongruences between how the results were summarized between the narrative written into the article and how the tabular summaries came out. The numbers weren't always correct, or the way they added them wasn't always correct. When I looked at, when I tried to scrutinize the numbers, I felt that it didn't really change their overall finding, but it potentially could change how one might look at some of their more minor findings. But in general, I think for the key things that they're looking for, they were still able to demonstrate that with the information as it was presented. So for the group, I have a few discussion questions, but I'm also open to anyone else's questions from the audience. And so the things that I'm curious about are if you agree with the author's conclusion that this skincare training is an effective prevention, whether it's surprising that skin protection training is not as commonly emphasized, despite how common it is as an occupational disease, and whether you think this training would be more effective in a worker who begins the job or once they've developed symptoms.
We start maybe with what's the purpose of the study?
Was to determine if applying a skincare prevention training program where they would learn about how to take care of their skin, if that would change how their, how the course of their skin disease would go, whether they would have resolution or not, or reduction in severity of their disease.
So then why do we need to talk about questionnaire development and all this other stuff? Not following why they went into that level of detail, and also not really following very well, why do you need controls?
They needed controls in order to have a measure, something to compare normal, non-diseased skin for transepidermal water loss compared to those that they collected as cases.
So, I'm not familiar with it. Did this study then also introduce the idea of using transdermal water loss as a measure of skin health?
It wasn't new, but it was proposing it as something to be incorporated into more common practice. It's not a tool that is available in most clinicians. Maybe dermatologists would have it, but this was done in a occupational medicine clinic.
What I'm getting at is that I mean, we've got questionnaire development, we've got basically an ecological study with cases and controls. Right? And we've got interventional study. This is reminiscent of what was done in the 50s, 60s, and 70s, but they would end up with a 50-page report. This one has problems all over the place because they're trying to do so much. I can't even, I'm having trouble. I'm all the way down to, for example, what it was the matching based on.
The matching, so those who had agreed to continue with the study and undergo that second clinical evaluation and get the training, that was 65 participants, and so they recruited 65 non-disease participants who didn't have disease and matched them for age and sex.
Well, that's not what's in the figure.
That's the part of what I mentioned, is that I found a number of kind of numerical mismatches between the way the data was presented in written words versus in tabular form.
Because what you, sex and age matched are in the text, but the figure has then job seniority matching. And then when we go to table 1, if we look at the variables, that's 659 paper, what do people think about those data? They match up. Say it doesn't look like very good matching to me, other than sex. That one I'll give you. Right. And then you got 41 versus 37 years of age. That's a pretty big difference if you're matching on age. I mean, usually you match based on age bands. You know, plus or minus 3 years or something like that. But to have that level of difference across the data is bothersome. It's more bothersome about the job seniority though, because that may be linked to the disease directly, the risk of dermatitis, right? So to me, that's beyond bothersome.
It was confused to try to follow their logic at times, and re-reference the tables and then not finding the same numbers, trying to add them myself or let's see.
And the dropout rate, you're hinting at it being not very good.
I guess depending, if 20% is reasonable, that's what the drop off was between those who got the training and then the 3-month follow-up. But before that was a pretty big drop. Just trying to get them from the initial interview to coming in to be seen.
Yeah, I mean, you've got more dropouts than you have people retained, right? It's, I don't know what the number is, 60% dropout rate. So you only know about people who are retained, which is really, trying to infer from the people who actually finished that they represent the overall group. And that always gets really hazardous.
So I think it can be presumed, and I think the article's authors presume that their drop off of those not wanting to participate in the study beyond the phone interview was due to them potentially having not as severe disease, but I don't think we can know that.
I mean, when you get disease patients, the other thing that happens with them is they also quit the job. There's healthy worker survivor bias issues that occur too. It can go in multiple directions. That's what's going on.
I thought it was an interesting idea to try to figure out if this is a way, it's something that can be incorporated into industry practice in terms of giving everyone a proper training protocol. But I don't know if they proved their point.
Yeah, and to that point, I'm more than happy to, and I will go quiet here. But what I'm starting with is the data and the quality of the data, and usability, reliability of the data, saying there's a bunch of problems here that are massive. So you can still go forward with it, but the underlying premise is challenged.
Anyone have any thoughts on the rest of the questions?
Hold on, I've got a comment from Claudia online. She says, I think it is not surprising that skincare protection is not emphasized because you are usually worried about getting the job done. Seeing the patients you have to see in the allotted time, but taking care of the caretaker is a very important aspect that needs to be addressed.
But certainly, I think from a managerial perspective, to try to emphasize that these things happen and they can be prevented, and this can mean protecting your livelihood. If that message comes from above, then I think it could do a lot of benefit for a company.
Do workers like to wear preventative gear?
Not, but if they start to recognize symptoms, I think they might feel different.
Anything else for Heather on this one? All right.
It's a challenging subject. I mean, maybe another couple of comments. We do not have wet machining operations here in Utah, but you can have people, it's a major problem in terms of dermatological issues. And then once you have it, it also becomes a problem because they oftentimes don't tolerate PPE either. So there's a lot of messes going on in here. And you are correct. For some people, it can be career ending. Finally give up. So, and managerially on the medical side, this is too, because you end up getting a job and keep getting exposed, then you keep having problems. So it is an important topic. It's just that the study is not very good.
I agree with you. Thanks, Dr. Eggman.
Right. Yeah, well, you know.
Sometimes employees. It's like, I'm sorry.
All right, everyone, while I'm swapping this presentation, I also wanted to take the opportunity to introduce those of you who have not met Dr. Erica Kleiner, who's a new faculty member with Romco. I wanted to introduce her. She's in the Department of Mechanical Engineering, and I know that everyone at Romco is very excited as you see her. So if you see her, say hi, all that stuff. Sorry to put you on the spot.
Everybody hear me? Well, good. All right, so I'm guessing this is my journal club presentation. So first, we're gonna go over our article review, go over the research design, sampling selection, how they extracted the data from the sampling that they did, the quality of the methodology that were used, the results, the discussion, and some strengths and limitations. So first, an overview of the article. So as we all know, the pandemic is pretty rough, and adherence to the social distance guidelines and regulations definitely caused an influx of dissonance for people with major mental illnesses or predispositions to them. And so what this study does is a meta-analysis over virtual reality as a potential form of mitigation to these experiences. And they do a screening in form of meta-analysis, and they pull results from 6 different databases. So the information pulled from these databases were gathered from December 2019 to December 2021. And they use the words VR, COVID, mental, psychological, and intervention as words to guide their search. And all of the studies that were included in the study were examined for the effectiveness. And they adhered to the preferred reporting items for systemic reviews and meta-analysis guidelines. So with this sampling, there was definitely some restriction and eligibility requirements. They did not enforce anything about geographic restriction. The studies that were included were all human studies published in English. And these were primary studies like case controls, cross-sectionals, cohort studies and things. There was no gender, race, or ethnicity restriction as well. And adults with or without underlying psychological distress were able to participate. And these interventions were permitted to be inpatient or outpatient as far as setting goes. Some people were excluded from the study, so children and adolescents were not able to participate. And the study only included articles with interventions that were via virtual reality as opposed to augmented reality. So augmented reality still displays things that are in your near environment, where virtual reality, everything is artificial. And the studies that didn't report the outcome of interest were omitted from the meta-analysis. So from the 6 electronic databases that they were pulling from, they gathered 379 references. And after their criteria was applied, only 4 of them were used. So the leading removal causes were title and abstract. There were 29 duplicate studies and 21 studies with the wrong study design that didn't fit with the goal of this study. And for measurement, they used both self-assessment tools as well as some predetermined scales like depression, anxiety, stress scale, general health questionnaire, and Beck depression inventory. So for quality assurance, they also did some additional rating. At the end of the article, there was a questionnaire that had questions yes, no, not addressed, and not applicable as optional answers. And for each yes, the study was given 1 point, and the studies with the most points were deemed to have the most effective results of VR as an intervention. They also used some additional scoring with the Master Critical Appraisal tool in quantitative studies, as well as Australian National Health and Medical Research Council. So here are their findings. So they had a section over psychological stress reduction, and VR reduction was proved to be the most satisfactory form of reduction as it pertains to VR. And there was a point that they elaborated on about being there rather than being in a real place. So software designers were able to use vibrant colors and scenery to enhance the realism. So although an image like this is obviously not real, with these vibrant colors and alterations to their virtual reality, they still felt a sense of immersion and being there. And this overall benefited to the ideal place. VR was also used as an intervention for recreational use. So they did another survey with 646 participants, and the results pretty much showed an overwhelming increase in mental and physical well-being. Fitness was surprisingly the second leading use of VR, behind gaming, of course. So participants usually reported about 1 to 4 hours of VR gaming and about up to 2 hours of VR physical fitness. And it's definitely increased the accessibility during the COVID pandemic because we weren't allowed to leave our homes, and so this provided a space where they were able to exercise that leisure. There's also a meditative effect in 2D versus 3D format that was analyzed here. So they wanted to line up the studies for face-to-face instruction with meditation and 360 VR video instruction. And they used a meditation breathing attention score to obtain the breathing scores to see if there was any notable difference. There was not. However, VR instruction was associated with more amazement, less embarrassment, but known to be more tiring. And for 2D format, this was associated with less distractibility and more exhaustion. Less exhaustion. VR was also used as an intervention for COVID-19 recovery units. So they were used in these units for stress alleviation, things like meditation, exploration, and cognition were components that were increased. Both patients and staff were satisfied with the implementation of VR in the CRUs, and patients said that it helped most with coping and rehabilitation. There were some more additional positive effects like increase in sleep, pain management, and VR and psychological intervention for patients with mental health problems. So patients reported a sense of immersion, escape, and engagement. They also said that they felt more self-empowered and that this provided them additional flexibility for implementing this into their busy work schedules, or let's say they were able to do these trainings at home as opposed to having to go to a physical place, which was of course not permitted during the pandemic. And notably, there was a knowledge gap involving the optimal duration and physical activity that was suggested when VR is in use. There was also some issues with tracking biological activity, like blood pressure, heart rate, vitals, things like this that you might be able to pay more attention to if you were in office as opposed to virtual. They did concede some limitations of VR as digital health interventions. Most notably, the time limitation for healthcare personnel. Obviously, the need for healthcare personnel and their attention was pretty dire in the pandemic, and the use of VR usually involves some type of orientation and to get the patient familiar with the technology. And of course, time is of the essence in this incident. And there was also some economic accessibility issues. So although VR has become a little bit more financially accessible these last few years, it is still something that needs to be purchased by patients. And it is entirely dependent on connectivity and Wi-Fi. So if you live in a remote area, you're not able to have access to Wi-Fi or Wi-Fi that has the appropriate bandwidth to be able to sustain a stable connection for the VR. The strengths of the study. So they were pretty pioneering their systematic review of VR as it pertains to COVID-19, because of course the pandemic was fairly recent and the development of VR and its accessibility was very recent as well. They explained their findings pretty thoroughly, I would say, and systematic literature search to all resources kind of prevents selection bias or minimizes it at least. They did a good job of applying VR to multiple different fields and domains. They explained their screening process in great depth, I feel like. And there was also the use of multiple electronic databases to try to maximize the amount of data that was being input into this meta-analysis. Limitations, this was pretty robust, and since they did go in depth, it might have been difficult for the reader to acutely examine the limitations and strengths. There were also some intrinsic flaws with the systematic review, so including self-assessment as well as these type of tools that were administered could have some selection bias and self-assessment flaws. Also, I noticed the exclusive use of English studies could have been a limiting factor. Although there was no geographical restrictions in place, if you're only using English studies, that definitely limits the amount of people and information that you're able to put into this meta-analysis. And although the filtration and screening process was rather extensive, perhaps in this excess filtration, some good studies could have been omitted that could have provided some valuable information to the study. So some questions for you. What are some methodological approaches that researchers could have done to strengthen the article? I thought that the use of more than just English studies could have helped a lot, again, with the studies that were included, as well as being consistent with the assessments, because people are probably going to assess themselves a little differently than a medically trained professional would. The next question is, has the end of the pandemic rendered the use of VR as an intervention obsolete?
Let's go back to the first question, because it's a really good question, and I just want to see if others have thought about that. A really good question. So if we look at their thrust of their paper, it's the role of VR as a psychological intervention for mental health problems during the pandemic. So first of all, what kind of study design would you want to see? I want you to answer. Somebody else answer. Dr. Thies tell you.
Like a control trial, like a.
Trial of pre-post intervention would be one thing you could do, but stronger design than that to determine what is effective for treatment. What is the
Random
study?
double blind.
Yeah, I think I just heard it.
Random
controlled
double-blind.
trial. Yeah. RCT. And in fact, one of the articles in here is an RCT, but it's only one. Now, the next challenge you have is then if you look at this, know that on a good note, and I really appreciate Heather bringing up a paper that's kind of all over the place and you're having a hard time reading it. This one, you could actually duplicate the methods because it's got that specificity, right? So that's really, really good. You've got the search terms here. Now, the challenge you have, I think, is and the search terms are at the bottom of page 2. And basically the last slide paragraph. You have to always think, did that narrow things excessively or fail to hit the target to answer the question? I must be thinking there's a problem, otherwise we wouldn't be asking this question. I could be right or wrong. Is there a broader literature base that you should be looking at? Okay, Emily is nodding her head, yes. Of course, she's a search expert, so. You know.
I'm sorry.
Yeah, just looking at their databases, they don't have Google Scholar. That's a huge one that people use for gray literature, a really wide net. I would say also with their search terms, they only have the word intervention. They don't narrow it down to randomized or anything, which maybe that's given the amount of quality or the amount of literature that they have, but if you really want to narrow in on a certain study design, you should use those certain terms. I don't know if I answered your question.
Those are great answers. How about another one? How about, do you need to narrow using the word COVID? Probably shaking the head no. I agree with that. Which is to say, you're throwing oodles of literature off the planet. And it begs that question that you're raising, which is why? Now you're assuming that everything else in mental health, you know, treatment and dealing with workers and all that sort of stuff has no value. It's like, right, that's a pretty big assumption. That's a pretty big database. Not VR and stuff. So anyway, that's my concern about that way too much other stuff. And of course, once you say you're gonna not narrow it to just a COVID or do a compare and contrast, now you got workload to do. And if you want to have a publication, well, you'd have one publication instead of three, because you sink so much time into it, but you know, the value of doing a compare and contrast is far superior than to narrow it down and be potentially misleading. in my opinion.
Second question was, has the end of the pandemic rendered VR as a use of intervention obsolete? I think it's definitely shifted their perspective because now people are permitted to leave their homes and to seek interventions in different ways that don't have to be exclusively virtual. But I do think with a myriad of other things, allowing these types of interventions to be virtualized could contribute to healthcare.
I guess, just from reading the conclusion, I'm not sure it ever, at least from this article, that it ever really helped. It's hard to, I don't find like, maybe I just missed it, but an obvious place where they say like virtual reality as an intervention either works or doesn't, or is unknown. It seems like it.
That's an option, so, you know.
Yeah, like maybe something that you should comment on. Maybe I missed it.
There's actually a pretty sizable database, as you can imagine, based on my prior response of the use of VR to treat a number of disorders, including things like PTSD. And dealing with exposure, re-exposure therapy. In other words, you're getting exposed to the things which produce in the first place to basically desensitize you. So there's a lot of stuff out there on this, and I think the cut to the chase is you're raising another very good question, which is I think if I'm reading into, well, maybe you should just say what your opinion is of number two. I shouldn't say it for you.
I would say there's a space for it. Now that things have been able to be mitigated virtually, I definitely think there is a space for it. And with this technology, it would kind of be a shame if this was to just die off in COVID. I think it's a resource that could be used and applied in other fields.
Do you think this is the last pandemic the world will see?
I sure hope so, but
Yeah.
probably not.
Yeah. I hope so too.
Yeah, right.
But I imagine the younger people might encounter one or more, you know?
We conquered germ theory. We figured that out. It's over.
Oh, and by the way, I didn't look, but the Utah was not one of the states where you could have left your family anytime. You were never ordered to be in your home. There are 8 of those states in the United States made the right choice, basically, in my opinion. But this would be one of those things where there may have been differences based on location, right? In fact, striking differences. So that would be actually a variable to look at in terms of the studies that they did.
Questions?
Got a comment from Micah online, and he is asking, do you happen to know if there was any discussion about whether the populations from the 4 studies were using other treatment modalities as well?
That was something that was discussed. I think that's a notable factor to be considered in this study.
Well, I don't, maybe somebody here knows the answer, but I don't know, like, for a systematic review like this, like, what's a number of articles that you would want to see to be able to draw any sort of conclusion out of it? 4 seems small to me, but is that a good number or?
I mean, isn't it dependent on like the amount of research out there? If there's nothing
Sure.
out there, then you can't have 100 articles to conclude something on. You have to go with what's there. But like what Dr. Abbott said, using the term COVID itself excluded a lot of data, so there could have been more that were applicable to this analysis. But because they didn't have it in the title specifically or in the search methodology, they could have just missed a lot of stuff. So.
We just had this discussion with the residents in the research class. Does somebody remember the lesson? About numbers of systematic reviews, numbers of articles, does that ring a bell? Yeah.
About was. You get worried if you see more systematic reviews than you do actual articles. So if you have 4 articles on a certain topic, and then there's like 25 systematic reviews on those 4 articles, it tells you that people are either trying to mine the data or they're trying to figure out different ways to make the data fit what they want to show from those studies.
Got real hardcore numbers on that, you know, and the examples that we've actually looked at are anti-inflammatory medications and treatment, and you've got like 50 RCTs and 10 systematic reviews. Don't ask me why you need 10, but there are. And then when you get to something like pain injections and stuff like that, you'll have 4 studies and you'll have 15 systematic reviews, okay? And the cut to the chase, in my opinion, the thing I'm drawing is that the financial conflicts of interest are driving that. And so just be alert to motive. It's a sad thing to say, but it is life that you have to at least think about motive. Underlying studies, is there motive? And you can make money in VR. And yet there's a lot of studies that are positive, you know, and you could say there's a rationale for them to be positive too. I agree with you. So I'm guessing that it's got efficacy, but
That's an interesting point to that. I know some PhD programs, they require their students to do a systematic review first before doing anything else with their research. But it's interesting because is it needed? So if every PhD student does a systematic review, is that also inflating the number?
All right, everybody, no journal club next week. We had a scheduling conflict. So no journal club next week. If you show up here, it'll be very lonely, but you're always welcome. Obviously, we'll be next week after next week.